Let me tell you about something I see almost every week in the emergency department that makes very little sense on the surface. A patient comes in, usually somewhere between 50 and 65, complaining of exhaustion so severe that they can barely function. So I go through the standard checklist. I check their thyroid. It's normal. I check their full blood count for anemia. Normal. I check their iron stores, their B12, their vitamin D, all within the reference range. I ask about their sleep. They're getting 7 hours. I ask about stress. Nothing unusual. I ask about their heart, their lungs, their kidney. Everything comes back clear. And I'm standing there looking at someone who on paper is the picture of metabolic normality, and they are absolutely exhausted, not just tired in the way you are after a long week. Exhausted in the way that makes getting through a normal day feel like running a marathon in wet clothes. They've been living like this for months, sometimes years. They've seen their GP, had the blood tests, been told everything looks fine, and been sent away with a suggestion to sleep more or reduce stress. Here's what makes this so frustrating. They aren't exaggerating. The fatigue is real. The suffering is real. And the tests really do come back normal because the test being ordered isn't looking for the right thing. There is a system running in the background of their biology that is malfunctioning in ways that standard blood panels are not designed to detect. A system that governs energy production at the cellular level, that regulates how oxygen is delivered to tissues, and that determines whether your mitochondria, the tiny powerhouses inside every cell, are operating at full capacity or running on flat batteries. What is causing the fatigue isn't in the thyroid result or the hemoglobin count. It's in the cell itself. And once you understand the mechanism, you will understand why conventional testing misses it and what can actually be done about it. Hi, I'm Dr. Michael. I'm an emergency medicine physician, and after nearly 11 years working in acute care, I have seen fatigue in its most severe and medically complex forms. Fatigue that has been misdiagnosed, undertreated, or simply dismissed because the standard workup came back normal. My focus now is on helping people understand what's actually driving their symptoms at a biological level so they can have informed conversations with their medical team and make changes that genuinely move the needle. If you're watching this video, you are probably someone who is exhausted in a way that sleep isn't fixing and frustrated that the medical system hasn't given you a satisfying explanation. I want to make you a promise. I promise to keep creating videos that are grounded in the best available science and in real clinical experience, not generic wellness advice, but the kind of mechanistic understanding that actually helps you make sense of what your body is doing. All I ask in return is that you give this channel a chance and hit the subscribe button. If you reach the end of this video and don't feel you've learned something genuinely useful, then unsubscribe. I mean that sincerely, no hard feelings. But if you give me your attention, I will give you everything I have learned from over a decade working on the front line of medicine. Please hit subscribe, help this channel reach more people who need this information, and let's get into it. To understand what causes this kind of persistent, investigation-resistant fatigue, we first need to understand how the body actually produces energy. Because most people have a surprisingly incomplete picture of this process, and the gaps in that picture are exactly where the problem hides. Your body produces usable energy through 3 interconnected systems. The first is the mitochondrial energy system, the process by which your cells convert fuel, primarily glucose and fatty acids, into a molecule called ATP, adenosine triphosphate, which is the actual currency of cellular energy. Every muscle contraction, every nerve signal, every organ function runs on ATP. Without sufficient mitochondrial output, everything in your body runs slower, less efficiently, and with more effort. The second system is the oxygen delivery network, the combination of your cardiovascular system, your red blood cells, and the hemoglobin molecules inside them that carry oxygen from your lungs to your tissues. Mitochondria require oxygen to produce ATP through the most efficient energy pathway available to the body. When oxygen delivery is impaired, even subtly, mitochondrial output falls and energy production becomes less efficient and more metabolically costly. The third system is the hormonal and neurological signaling network, the communications infrastructure that tells your cells when to ramp up energy production, when to conserve resources, and how to respond to the demands being placed on the body. This network includes your thyroid hormones, your adrenal hormones, your autonomic nervous system, and a collection of signaling molecules that most standard blood tests do not routinely assess. In a well-functioning state, these three systems work in seamless coordination. You need energy. The signal goes out, mitochondria ramp up, oxygen arrives, ATP is produced, and you have the capacity to do what you need to do. The fatigue that defies standard investigation occurs when one or more of these systems is compromised, not catastrophically, but sufficiently to reduce cellular energy output below the threshold required for normal daily function. Here is where the conventional approach to investigating fatigue has a critical structural limitation. The standard blood panel ordered for a fatigued patient is designed to rule out the most common, most medically serious causes of fatigue: anemia, hypothyroidism, diabetes, kidney disease, liver disease. These are important diagnoses, and the tests that detect them are genuinely valuable. But those tests are looking for overt disease in specific organ systems. They are not designed to assess mitochondrial function. They are not designed to detect subtle impairments in cellular energy metabolism. They are not designed to identify the early stages of dysfunction in the hormonal signaling systems that govern energy production. Dysfunction that is real, measurable, and clinically significant, but that does not yet meet the threshold for a diagnosable condition on conventional testing. Research published in the journal Mitochondrion has demonstrated that mitochondrial dysfunction, including measurably reduced ATP production and impaired electron transport chain activity, be present and clinically symptomatic in patients whose standard metabolic panels appear entirely normal. The dysfunction is happening at a subcellular level that routine blood chemistry is not structured to detect. This is not a failing of the doctor ordering the tests. It is a structural limitation of the testing framework that was designed decades before our understanding of mitochondrial and metabolic medicine had reached its current level. Think of it this way. Standard blood tests are like checking whether a car has fuel in the tank and oil in the engine. They will catch the obvious problems. What they won't tell you is whether the engine itself is running at full efficiency, whether the combustion process is clean and complete, or whether there is something impairing it at a mechanical level that doesn't show up in a dipstick reading. That is precisely the gap in which this form of fatigue lives. So what is actually causing the fatigue? In a significant proportion of patients with persistent, unexplained exhaustion, the primary driver is cellular energy insufficiency, a state in which the mitochondria are not producing ATP at the rate the body requires, either because of impaired mitochondrial function itself, because of insufficient supply of the substrates mitochondria need to operate, or because of chronic oxidative stress that is damaging mitochondrial membranes and reducing their efficiency. There are several specific mechanisms by which this develops, and they operate independently but often simultaneously. The first is coenzyme Q10 deficiency. CoQ10, ubiquinol in its active form, is an essential component of the mitochondrial electron transport chain, which is the biochemical assembly line that produces the majority of the body's ATP. Without adequate CoQ10, electron transport slows, ATP output drops, and the mitochondria generate more oxidative byproducts as a result of their inefficiency. CoQ10 levels decline naturally with age are further reduced by statin medications, one of the most widely prescribed drug classes in the over 50 population, and are not assessed by any standard fatigue blood panel. That last point bears repeating. If you are over 50, taking a statin for cholesterol management and experiencing persistent fatigue, the statin itself may be a direct contributing factor through CoQ10 depletion, and this connection is almost never discussed with patients at the point of prescription. The second mechanism involves chronic low-grade inflammation impairing mitochondrial function. Research published in Nature Reviews Immunology has demonstrated that inflammatory cytokines, signaling molecules produced by the immune system in response to chronic stress, poor diet, disrupted sleep, or latent infection, directly suppress mitochondrial activity. They do this as a conservation mechanism. The immune system diverts energy resources toward its own demands. In the short term, this is adaptive. In the context of chronic unresolved inflammation, it produces a sustained reduction in the cellular energy available for every other physiological process. The third mechanism is subclinical thyroid dysfunction. Thyroid hormone levels that are technically within the normal reference range, but sitting at the lower end of that range in a way that is physiologically meaningful for energy production. The thyroid is the master regulator of metabolic rate. It controls how fast mitochondria work, how efficiently cells produce ATP, and how responsive every organ in the body is to energy demands. A TSH reading of 3.5 is clinically normal, but research published in the Journal of Clinical Endocrinology and Metabolism has shown that optimal thyroid function for energy and cognition in most adults corresponds to a TSH in the lower half of the reference range. The difference between a TSH of 1.2 and 3.8 is not visible on a blood result flagged as normal. It is very much felt by the person carrying it. This is the hidden cause, not a single dramatic diagnosis, a convergence of subclinical impairments in the cellular energy production system, each individually beneath the detection threshold of standard testing, but collectively sufficient to produce fatigue that is real, measurable in its impact on daily function, and entirely unexplained by the results on the page. So let me name this explicitly. The hidden cause of fatigue that most doctors miss is not a single condition. It is a pattern of subclinical cellular energy failure, impairments in mitochondrial function, coenzyme Q10 status, inflammatory burden, and thyroid signaling that individually fall below the diagnostic threshold and collectively produce fatigue that is genuinely debilitating. And the reason it keeps getting missed is structural, not personal. The medical system is organized around diagnosing named conditions. When the tests rule out those conditions, the clinical pathway effectively ends, not because the doctor doesn't care, but because the system has no established protocol for the territory between demonstrable disease and perfect health. That territory is where a very large number of fatigued people actually live. This shows up in a specific and recognizable pattern. The most common presentation is fatigue, that is worst in the morning, not relieved by sleep, not explained by a particularly demanding previous day, and accompanied by a sense of physical heaviness that makes the first few hours of the day disproportionately difficult. This pattern is characteristic of mitochondrial insufficiency because ATP stores are depleted by overnight physiological maintenance processes and are slow to rebuild when the mitochondria are not functioning efficiently. The less obvious presentation is what I call effort intolerance, the experience of activities that were previously unremarkable now requiring a recovery period that feels disproportionate to the exertion. Climbing a flight of stairs feels different than it did 5 years ago. A busy afternoon leaves you unable to engage in the evening. A single demanding social event requires a day of recovery. This is not laziness or deconditioning. It is the body's energy production system being unable to meet a demand that its ATP output cannot sustain. There is also a cognitive dimension that is frequently overlooked. Mitochondria are not only present in muscle and organ tissue, they are dense in the brain, where the high metabolic demands of neural function make them particularly vulnerable to insufficiency. Brain fog, word-finding difficulties, reduced ability to concentrate, and a general slowing of cognitive processing speed are all consistent with reduced cerebral ATP availability. These symptoms are often attributed to stress, hormonal changes, or aging and dismissed accordingly. Then there is the pattern of fatigue that worsens progressively across the day, despite adequate nutrition and hydration. This is often driven by the inflammation component. Inflammatory cytokines increase throughout the day in response to activity, dietary intake, and environmental stresses, progressively suppressing mitochondrial output as the day advances. By late afternoon, the cellular energy deficit has compounded to the point where functioning requires an effort that feels far out of proportion to what is being asked. Persistent fatigue does not develop because you have failed to manage your health. It does not persist because you are not trying hard enough, or because there is nothing genuinely wrong. It persists when a set of subclinical biological impairments, real, measurable at the right level of investigation, and entirely treatable, never gets the clinical attention it requires because the standard testing framework was not designed to find it. The system was not built to look where the problem actually is. That is not your failure, that is a gap in the diagnostic architecture. So what is the solution? I want to frame this carefully. I am not suggesting that everyone with fatigue has mitochondrial dysfunction, or that the approaches I am about to describe replace a thorough medical evaluation. They do not. Fatigue has many causes, some of which are serious and require conventional medical treatment. What I am saying is that if you have had a standard workup, been told everything is normal, and are still exhausted, there are evidence-supported practical steps that address the specific mechanisms we have discussed. If you are taking a statin medication, the relationship between statins and CoQ10 depletion is well established in the biochemistry literature, even if it remains underemphasized in clinical practice. Statins inhibit the mevalonate pathway, the same metabolic pathway the body uses to synthesize CoQ10. The result, in a meaningful proportion of statin users, is a reduction in CoQ10 availability that impairs mitochondrial function and contributes directly to muscle fatigue and generalized exhaustion. Research published in the journal Biofactors has demonstrated that CoQ10 supplementation in statin-treated patients with myopathy and fatigue produces measurable improvements in energy levels, muscle symptoms. The dosage studied in most of this research is in the range of 100 to 300 milligrams daily of the ubiquinol form, which is the more bioavailable reduced form of CoQ10. I want to be clear that this is not a recommendation to self-prescribe. Please discuss it with your prescribing doctor. But it is a conversation worth initiating, particularly if you have been on a statin for years and have noticed a progressive decline in energy since starting it. Recall what I said about inflammatory cytokines directly suppressing mitochondrial activity. Reducing the burden of chronic low-grade inflammation is one of the most effective ways to restore cellular energy output, and the most powerful dietary lever for achieving this is reducing ultra-processed food consumption while increasing intake of whole foods rich in polyphenols and omega-3 fatty acids. Oily fish, salmon, mackerel, sardines provide EPA and DHA, the omega-3 fatty acids with the most robust anti-inflammatory evidence. Extra virgin olive oil, consumed as the primary fat source, provides oleocanthal, a compound with inflammatory signaling properties comparable at high intake to low-dose ibuprofen. Dark berries, leafy green vegetables, and turmeric all provide compounds that measurably reduce inflammatory cytokine production. These are not fringe claims. These mechanisms are documented in research published in journals, including Cell and the American Journal of Clinical Nutrition. This approach is not about eliminating food groups. It is about consistently replacing the inputs that sustain chronic inflammation with inputs that reduce it, and giving the mitochondria an environment in which they can function at closer to their designed capacity. Physical activity is one of the most powerful stimuli for mitochondrial biogenesis, the process by which the body creates new mitochondria and increases the density of existing ones. Exercise creates what is called a metabolic stress signal that the cell interprets as a demand for greater energy production capacity. The response is to build more mitochondria and to upregulate the enzymes involved in ATP production. The timing dimension is particularly important for fatigued patients. Research published in the Journal of Physiology has shown that moderate aerobic exercise performed in the morning before the inflammatory burden of the day accumulates produces greater mitochondrial adaptation than equivalent exercise performed in the evening, and is better tolerated by people whose energy reserves are already compromised. Starting with 15 to 20 minutes of low-intensity aerobic activity performed consistently is a more effective mitochondrial stimulus than occasional high-intensity efforts that leave the body depleted and inflamed. Think of it like a savings account. Small, consistent deposits build the balance over time. The balance here is mitochondrial density and efficiency, the foundational asset of sustainable energy production. If your fatigue has been investigated and the standard results are normal, there is a set of more targeted tests that can illuminate the subclinical drivers we have discussed. A full thyroid panel, including free T3 and free T4, not just TSH, provides a more complete picture of thyroid hormone availability at the tissue level. Ferritin, the iron storage marker, can be low in a way that impairs energy even when hemoglobin is normal. Optimal ferritin for energy function is generally considered to be above 50 micrograms per litre, though many laboratories flag anything above 12 as normal. Homocysteine and high-sensitivity C-reactive protein are markers of inflammatory and methylation pathway function that are rarely ordered in routine fatigue investigations, but are highly informative. I want to be explicit here that I am not suggesting you self-diagnose or self-treat based on these markers. I am suggesting that if you are a fatigued patient who has been told everything is normal, you have every right to ask your doctor for a more comprehensive investigation and to have an informed conversation about what that investigation should include. Everything discussed in this video is intended as educational context, not personalized medical advice. Fatigue is a symptom with a broad differential diagnosis, some elements of which require urgent medical attention. If your fatigue is new, severe, or accompanied by other symptoms, chest pain, shortness of breath, unexplained weight loss, or neurological changes, please see your doctor without delay. And please do not stop or adjust any prescribed medication without first discussing it with the clinician who prescribed it. Let me bring this back to what I see clinically, because the pattern in practice is consistent enough to be striking. The fatigued patients who make the most meaningful recovery are almost never the ones who find a single dramatic diagnosis. They are the ones who work methodically through the layers, addressing inflammatory load through diet, supporting mitochondrial function through targeted nutrition and consistent low-intensity exercise, getting a more complete thyroid picture, and in the case of statin users, having a frank conversation about CoQ10. What is remarkable is how quickly the biology responds when the right inputs are addressed. I have seen patients who have been exhausted for 2 or 3 years begin to report meaningful improvement in energy within 6 to 8 weeks of making these specific changes. Not a return to the energy of their 20s that is not a realistic frame, but a recovery of function that allows them to live their normal life without the constant expenditure of effort that fatigue demands. That is not a placebo response. That is the mitochondrial system being given what it needs to operate more effectively. There is also a clinical observation that is worth sharing. The patients who understand the mechanism, who know why they are tired at a biological level and why the interventions they are making are addressing that specific biology, have substantially better outcomes than those who are simply following instructions. Understanding drives adherence. Adherence drives results. That is why mechanistic explanation is not an academic exercise. It is a clinical tool. Fatigue is not just an inconvenience. At a deeper level, it is a signal that cellular energy production is running below the threshold required for the body to maintain itself optimally, and that has consequences that extend well beyond the experience of feeling tired. The mitochondrial dysfunction and chronic inflammation that drive this kind of fatigue are the same mechanisms implicated in accelerated cardiovascular aging, cognitive decline, immune dysregulation, and the progressive loss of physical capacity that most people associate with getting older but accept as inevitable. They are not inevitable. They are, in a significant proportion of cases, the downstream consequence of an energy production system that has been running below capacity for years, and that is responsive to intervention. When you address the root cause of this fatigue, when you restore the conditions in which mitochondria can function efficiently, inflammation is held at a level the body can manage, and cellular energy production meets the body's actual demands. You are not just recovering from tiredness, you are restoring the biological foundation on which resilience, cognitive capacity, physical strength, and healthy aging all depend. That is a profound return on what are, in most cases, remarkably modest investments of effort and attention. So let me bring this full circle. The fatigue you are experiencing does not mean there is nothing wrong. It does not mean you are imagining it, exaggerating it, or failing to manage your life adequately. It means there is something happening at the cellular level that the standard diagnostic framework was not designed to find, and that has been allowed to persist precisely because the test said normal. The solution is not to accept the exhaustion as permanent or to push through it without understanding what is driving it. It is to address the specific biological mechanisms, CoQ10 status, inflammatory burden, mitochondrial capacity, thyroid signaling, with the kind of informed, targeted approach that gives the cellular energy system what it actually needs to recover. Fatigue that defies investigation is not a dead end. It is a pointer to a different level of investigation. And now that you understand the mechanisms involved, you are in a far stronger position to pursue that investigation and to make the changes that will move things forward. And if you found this video useful, please subscribe to the channel. It helps us reach more people who are sitting with exactly this frustration and who deserve a proper explanation. Thank you for watching.